Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The clinical laboratory is a valuable source of supplemental diagnostic information. Laboratory studies are ordinarily done when there is an indication from the patient's history, clinical examination, or radiographic findings. The clinical laboratory employs the examination of body tissues, fluids, excretions, and secretions. The following demonstrations will illustrate the collection of the various specimens for shipment to the laboratory. The collection of a bacteriologic specimen is done for the purpose of identifying a pathogen which has caused infection in the oral cavity, and also to determine what antibiotics may be effective against the pathogen or pathogens. The equipment that is used for the collection of the specimen is a flame source, sterile containers, cotton tip applicators, and a wire loop. First, we will show the collection of a specimen for gram staining and immediate identification in the laboratory. For this purpose, we will use the wire loop, or in this case, a small platinum spatula, which has been previously sterilized by flaming it. We will collect our specimen from the soft palate region by light scraping of the area where we expect to see or find some growth of the pathogenic organism. Having done this, we will pick up the slide which has on it the patient's name, date, and the registration number of the patient or other identification number. Then we will smear the material evenly over the surface of the slide. In order to get a more even and wider distribution of material, it's possible to place a small drop of water or physiologic saline, which has been sterilized previously, on the slide to facilitate the spreading action. The loop is again sterilized by flaming to destroy any pathogens that may be adherent to it following the removal of the specimen from the mouth. Next, we will show the method of obtaining the specimen for smearing on culture media in the laboratory. And to do this, we will use a cotton tip applicator that has been sterilized and placed in a glass tube. First, we will remove the cover and flame the opening to remove any possible bacteria that would contaminate our specimen. And we will remove the applicator, go to the oral cavity, and swab from the same area and remove the specimen. Again, remove the cover, flame, place our specimen back in the sterile tube, cap it, and it's ready for shipment to the laboratory. It's important that these specimens be sent to the laboratory in as short a time as possible, that is, within a matter of a few hours. It may be necessary to incise and drain an abscess in the oral cavity for relief of the infection and the accumulation of exudate in the infection. At the same time this is done, it's possible to collect a specimen from the area for examination in the laboratory. This is done by, first of all, drying the area where the incision is to be made. As we are simulating here, next the area is painted with an antiseptic solution such as Macressin, as we have here, to destroy as many of the contaminants in the field as possible. Then with a sterile scalpel, the summit of the abscess is incised and the pus is allowed to come to the surface. As it comes to the surface, the first portion is wiped away with another sterile gauze square, and then the sterile applicator is applied to remove some of the exudate for examination in the laboratory, and is handled in the same way as we did previously in collecting the specimen for culturing from the soft palate. This concludes our section on the obtaining a bacteriologic specimen for laboratory examination. Exfoliative cytology is a laboratory procedure of limited value for the examination of cells that are removed from the surface of tissue in the mouth that may be cancerous in character. It also is used for the examination of fluid that is removed from vesicles that may arise in the oral mucosa. The equipment that is used for the collection of the specimen is relatively simple. A laboratory sheet that is to be sent with the specimen to the pathology laboratory should be made out in some detail. It should include, of course, the patient's name and the date and identification number. Also, some of the characteristics of the lesion, such as the length of time that it's been present, the site from which it came, and something about its clinical appearance. Glass slides are needed on which the specimen can be smeared, one end to be frosted so that the patient's name and the date and identification number can be recorded there. A fixer solution, an applicator for the removal of the specimen, or to tidy up the area before the removal of the specimen, and tongue blades which are also used for the removal of the specimen from the surface through scraping. We'll go to our patient and examine an area from the right corner, the right anterior buccal mucosa, an area of superficial change that shows some irregularity in its periphery. It has somewhat of a red base and a hyperkeratotic area around the circumference. We will dry off the area somewhat and remove any excessive debris that may be there. We could, in fact, use this to smear one of the slides. We then pick up our tongue blade and again go to the lesion and scrape vigorously so that we get material from the base of the lesion. It's important that we get cells down at the bottom or the base in order that we have those that are developing and maturing rather than those which are entirely keratotic from the surface. After we have spread the material thoroughly on the surface of the slide, we will fix it and as quickly as possible so that the character of the cells does not change. So that we don't spray our patient, we move aside and flood the surface of the slide with the fixative material. When the slide has dried, it is then ready for shipment to the pathology laboratory for examination. This concludes the portion on exfoliative cytology.
Venipuncture technique is a technique used for most hematologic studies, blood coagulation studies, and biochemical studies run on the whole blood or the blood components, either serum or plasma. The technique for obtaining the blood is through a venipuncture. There are two main methods of obtaining this blood. One is through the needle and syringe, and the other is through the Vacutainer. The needle and syringe will be the technique we'll demonstrate first. It is an older technique, much more easy to learn, and much less difficult to accomplish for novices attempting this for the first time. The second technique, the Vacutainer, is a little bit more difficult to manipulate, but is the most commonly used technique because it involves one stick of the patient and you can draw multiple tubes, and it lends itself to large-scale, large lab operations. The equipment necessary to draw the specimen is the 10 cc Luer lock plastic syringe, the 21 gauge 1-inch disposable hypodermic needle, a rubber tourniquet, 70% alcohol, gauze squares, Band-Aids, and ammonia inhalant. The ammonia inhalant is necessary in case the patient passes out. Demonstrating the use of the plastic disposable syringe, there are two ear tags that can be separated. There is a plastic guard on the end of the syringe that should be removed, and the syringe should be tested. It's always better to test to make sure the rubber stopper does not stick before having this placed in the patient's vein and finding out it doesn't work at that time. The 21 gauge disposable needle comes in a disposable packet, again with two ear-like tabs. These tabs are torn back, exposing the hub, which is screwed tightly on the syringe. The protective cover is loosened and again tested to make sure that there's no blockage. Proper application of the tourniquet is very important. The tourniquet should be placed for maximum use during the venipuncture, but also for comfort for the patient. One method of making it more comfortable is to put your finger underneath the tourniquet so your finger is between the patient's arm and the tourniquet, pulling just the right arm tight to make the tourniquet tight, tucking it up under by lifting the tourniquet away from the arm and then releasing it back down. What this does is makes it so you don't pinch the patient. Also, the two arms of the tourniquet are up out of the field so they do not contaminate your needle or your specimen. This is also very useful in being able to do a one-arm release. By one arm, I can take this hand here, release the tourniquet, get it out of the field, and still have my other arm drawing the specimen. The tourniquet should be placed, again, 2 inches above the antecubital fossa. Once you place the tourniquet, do not delay too long. You will have your patient make a tight fist, but if you delay too long, you will congest the arm, which will interfere with the red blood cell count, the hemoglobin, and the hematocrit by getting congestion in the arm. So for hematologic studies, we must make this puncture quick, and we must be as accurate as possible. Now again, placing the tourniquet, the finger next to the patient, as tight as possible. Okay, have your patient make a couple tight fists. Then we will look for the best vessel. The antecubital fossa, the vessels I'm looking for are in this area. There are vessels off to the side. These are usually thin-walled vessels, and they tend to roll. There is a very large, deep vessel running right where my finger is pointing at this time. This is the vessel I'm going to go for. I can feel it doesn't move or roll around. So now I will pick up the syringe, the alcohol gauze, and the gauze that I'll use later. After having palpated, clean off the area in a circular motion, not rubbing too hard to set up an irritation or a wheel and flare reaction. I usually then like to dry the area off because the alcohol will sting. The bevel must be bevel up. You pull the skin tight, have the bevel up, go directly into the vessel. Now I'm moving my hand, and I still have a rest position on this side. So you will notice, you'll see some of the blood came out, and some of the blood is in the hub. Now I will draw the blood into the syringe, and here I'll be wanting probably about 6 to 8 cc's. Okay, after I have obtained the amount of blood I want, I'll have the patient release his fist. I will then one hand release the tourniquet, getting that out of the way. Picking up my gauze, I will tell the patient to just relax. I will pull the needle out and press down hard. The patient will then press down on this for me. Then he will take and hold his arm up. Do not have them bend their arm, as this just drives the vessels in deeper and they stand a better chance of getting a hematoma. After having distributed the blood, then we'll come back to our patient and see how the patient is doing. You'll notice that the coagulation mechanism is working fine. There is no bleeding in the area. There's no need for a pressure bandage. Bandage is applied as any other bandage would be. And we're all set with the syringe drawing technique. The Vacutainer technique just utilizes different equipment. It has the plastic Vacutainer holder, which is a syringe-like piece of plastic that holds the Vacutainer tube. We have a different needle, which must be used with a Vacutainer holder. Again, the needle is either 20 or 21 gauge, 1 to 1.5 inch needle. I will show you the difference between the two types of needles. This needle has a plastic sheath over the end of the needle that pokes into the Vacutainer. There is a small hole. This plastic sheath can be pulled back, exposing this hole to draw the blood, and then when a Vacutainer is removed, the rubber sheath comes back out and covers up the hole so no blood leaks out on the patient. Applying the Vacutainer needle to the Vacutainer holder is just as easy as screwing it right on. There's nothing really to test now as there was with the syringe. A Vacutainer, which is a test tube with an anticoagulant in it and a vacuum that draws in 4.5 cc's of blood, is then placed firmly on the Vacutainer needle. By placing it firmly, we must make a small puncture into the rubber and bring it up to this line. I think you can see the line right there on the Vacutainer holder. That holds the needle in place. With the Vacutainer and the Vacutainer needle all set, we are ready to go to our patient. Coming to the patient now, proper application of the tourniquet. Again, your finger between the patient's arm and the tourniquet. Tight placement of the tourniquet. Have the patient make a tight fist. Pump 2 or 3 times. And then we'll notice the vessel is rising up. This time we'll use one of the lateral vessels because it's easier to see. The vessel runs a course right along the side like this. So that means that when we do the puncture, we'll have to follow the course of the vessel. Another thing about this vessel is it's a more superficial vessel, so it has a tendency of rolling, which I think you can see it roll slightly. Now I know the arm is becoming congested now, but I'm more interested in showing the technique. After you have palpated the vessel, you have an idea about where the vessel lies, if it rolls or doesn't roll, then you will go ahead and clean off with alcohol and then not touch the vessel again. If you touch the vessel again, what will happen is you will contaminate the needle and contaminate the specimen and the patient. We'll dry off, take our Vacutainer, have the bevel up, pull the tissue tight, needle bevel up. Get yourself a rest position so that my hand holding the needle is resting on the patient. I then go right above the vessel, directly into the vessel. Now, the blood does not come into the Vacutainer tube until it is engaged. By engaging it, I merely press it so that the vacuum is coming and the blood fills up. Now I will show you the double draw technique. This automatically will pull in 4.5 cc's of blood and will stop. I remove this Vacutainer, mix the anticoagulant, and you'll notice the rubber slip has come over and is now not allowing the blood to come out except for a small drop there. I will then place another Vacutainer and again press it home into place, and we can draw as many tubes as we want. This way you can draw 1 tube for hematology, 1 tube for coagulation, 1 tube for biochemistry. Now, after I have attained as many tubes as I want, I tell the patient to release the fist, have the patient relax, release the tourniquet, get my gauze, pull the needle out, and correctly place a lot of pressure holding the patient's arm up. The patient will hold that. Again, we will then bandage the patient's arm up, and that is the only difference in the Vacutainer technique. An important clinical coagulation study that can be accomplished in the average dental office is the IV forearm bleeding time. This study is a very important study because it tells us both about the vascular phase and about the platelet phase of coagulation. The study cannot discriminate between vascular bleeding problems and bleeding problems due to decreased platelet function or decreased platelet number. All the study will tell us is there is a defect in the vascular or the platelet phase. The equipment necessary to do this study is a blood pressure cuff or sphygmomanometer, a sterile disposable micro lancet, a stopwatch, filter paper, 70% alcohol, Band-Aids, gauze squares, and ammonia inhalant. Coming to the patient, we'd want to inspect the patient's arm, making sure that when we make the small half-millimeter deep, half-millimeter wide puncture, we do not do it over obvious vascular areas such as this superficial blood vessel. So we'd want to do it in an area off to the side which is free of lesions and free of any erythema reactions which could increase the bleeding. So we select about a 3-centimeter site. Then we'll go ahead and apply the blood pressure cuff. The blood pressure cuff is applied as any blood pressure cuff for taking the blood pressure on a patient. It's applied snugly. Then we will inflate the cuff to get a standardized pressure on the vasculature to standardize the test and make it reproducible up to 40 millimeters of mercury. And you'll notice that we now have it at 40 millimeters of mercury. We will then cleanse the area that we have selected with alcohol, and again drying the alcohol off. Again, being careful we don't press too hard to not set up a wheel and flare or any reaction which would cause bleeding. We'd make 3 distinct punctures, 1, 2, 3, and start our stopwatch. The blood will well up, and you'll notice that 2 of the punctures are bleeding well and the other isn't. You take the filter paper, come up adjacent to the wound, but do not touch the wound, and draw the blood up. Again, we'll wait about 15 seconds, and again come up to the wound, drawing up the blood. About another 15 seconds, and you will notice that the bleeding has stopped at this point and is gradual at this point. You can see this because the blood was very large and then gradually diminished down the spots. This concludes the test. We would stop the stopwatch. The normal values are under 5 minutes. The normal range is 1 to 9 minutes. Most people will usually stop bleeding within 1.5 minutes to 2 minutes. We would release the pressure from the blood pressure cuff, remove the cuff, inspect the arm for any bleeding. If there was any, we would then put a Band-Aid over. This concludes the IV forearm bleeding time.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.